It's my pleasure to introduce our first plenary speaker of the day, Dr. Alfonso Fasano. Dr. Fasano holds the chair in neuromodulation at the University of Toronto and University Health Network. He's a professor in the Department of Medicine, Division of Neurology at the University of Toronto, a staff neurologist and co-director of the surgical program for movement disorders at Toronto Western Hospital, University Health Network, and the Hospital of Sick Children in Toronto. He's also a clinical investigator at the Krembil Institute and KITE, K-I-T-E, Toronto Rehabilitation Hospital, leading the CORE-E, closed-loop capabilities of the Center for Advancing Neurotechnological Innovation. He sits on the Scientific Advisory Board of the Dystonia Medical Research Foundation and International Essential Tremor Foundation. He's chair of the Normal Pressure Hydrocephalus Study Group and a member of the study group on tremors of the International Parkinson Movement Disorders Society. He's also a member of the Tremor Research Group and the Parkinson Study Group. It's amazing that we've got him here today because he's a very, very busy man. He received his medical degree from the Catholic University of Rome, Italy in 2002, became a neurologist in 2007. After a 2-year fellowship at the University of Kiel, Germany, he completed a PhD in neuroscience at the Catholic University of Rome. His main areas of interest are the treatment of movement disorders with advanced technology, infusion pumps and neuromodulation, pathophysiology, and treatment of tremor and gait disorders. He's authored more than 400 scientific papers and book chapters and is the co-editor of the section Gaps and Controversies in Movement Disorders Journal. He's also an editorial board member of Annals of Neurology, Movement Disorders Journal, Movement Disorders Clinical Practice, and Parkinsonism and Related Disorders. Additionally, Dr. Fasano is a principal investigator of several clinical trials. How can one person do all these things? In any case, again, we're very privileged to have you here. Please join me in welcoming Dr. Fasano.
For the past 10 days, I've been in 7, 8 cities, I guess, talking to a lot of doctors. But I can tell you the energy that, as a doctor, I feel in a room like this one is nothing close to what I've seen so far. So that's why it's always a gift for me to talk to patients associations, to people who are not doctors, because, you know, doctors can be quite boring sometimes. And besides, you know, it's part of my mandate, I think, because I completely agree with what you just heard. Sometimes giving a diagnosis to a person as being on the other side of the table. Actually, I don't even have a table in my office. I usually sit next to the patient. But when you're on the other side and you give a diagnosis to someone, you always wonder then what's going to happen at home. And so I think part of our job as physicians is to really push education and really get rid of the stigma. And Parkinson's is not just tremor. And that's why I'm really grateful that they've given me this talk to talk about the invisible problem of pain. But let me tell you that this is just a paradigm of many other problems that unfortunately people with Parkinson's might have, problems that the society might not know. And so that's really the reason I'm really happy to talk about this. So these are the take-home messages of my talk. What I'm going to tell you today is that pain is common, and I think you know that. That there are different types of pain, that very often the solution is not a painkiller. This is what I call the jukebox medicine. You know, you remember jukebox, that you go there and you select a song? There is this tendency in medicine that you go to the doctor, doctor, I have headache, okay, that's the anti-headache medication. Doctor, I have pain, this is the painkiller. It doesn't work always this way, actually should not work this way. And that's why it's important to know why people might have pain, because from there, you know what to do. So let's start with real stories, and that's the way I think things should be done. This is one of the emails I received from a patient of mine, and I highlighted what this person is talking about. He's not talking about fluctuations, rigidity, tremor, involuntary movements. He's talking about pain. And if you look at the very bottom, what he's saying is that I'm begging you to please help me. So this is a problem, this is common, and this is something that really has an impact on quality of life of people. And this is not just because I say it, there are studies, and I don't want to get too technical, but if you look at the right table, the table on the right, you see all numbers of problems, and they are ranked in order of their importance in determining the quality of life. And obviously, depressed mood is a big one, but you can see the pain is number 4. And once again, you don't see any tremor. You don't see any of the classic signs that people think are part of Parkinson's disease. People at the end of the day want to walk, they want to dress, they want to go to the bathroom, they don't want to have pain. This is what really matters to patients and to people in general. The other issues, which is unfortunately a big one, especially in North America, not so much in Canada, thankfully, is the prescription of drugs. Think about opioids medications. Again, back to the jukebox medicine. It's easy to go to an ER and you just want to get rid of the pain, they give you something, and they send you home, right? And there are studies like this one looking at the number of painkillers taken by people with Parkinson's, which by far are more frequent than the general population, especially when they are matched for age and sex. I mentioned already that as part of this invisible part of the disease, there are a number of non-motor problems. And actually, the most common non-motor problem in Parkinson's are gastrointestinal issues, constipation, issues with saliva. There are many problems with digestion, but pain is right after GI symptoms. As you can see, there is number 2. How common is it? These are just few studies. You don't have to remember the names of whoever wrote these papers. You just need to look at the numbers on the right. And as you can see, up to 95% of interviewees of studies have been saying that they had pain. These are all people with Parkinson's. Have you heard about the PPMI cohort? It's something that the Michael J. Fox Foundation put together. It's a group of people that have been followed for many years, ever since diagnosis, and actually even few years before, because they could track back the initial problems that they had. And these people have been following for years now, because the idea here is to try to figure out what's the best biomarker of the disease. So they're getting lumbar puncture, blood tests, MRIs. And in this cohort, as you can see, it was clear that a lot of problems were seen well before the diagnosis, but even well before the occurrence of motor problems, because to this date, we still diagnose Parkinson's based on motor problems. But in reality, Parkinson's can start many years before with sleep problems, with constipation, with lack of smell. In some people, quitting smoking all of a sudden. I know smoking is no longer common, but in the past, when people were smoking, quitting smoking all of a sudden with no real reason could have been seen as an initial sign of Parkinson's disease. But in this study here, they didn't mention pain, and probably pain is not that common before the disease starts. Yet, if people are asked, what's your most bothersome problem? And in this study, they divided early PD versus moderate PD. In the early PD group, as you can see, pain is the number 4 sign and symptoms described, while in the other group, they call it advanced, they have more problems with fluctuations. And we're going to talk a little bit about fluctuations today, because that's also relevant to pain management. So what happens over time? All the symptoms that you see on the right, the ones that are gray, are problems that tend to worsen over the 2-year period. All the ones that you see on the left, they tend to get better. So remember, not everything gets worse with time. Some things get better. So an example of this is actually apathy, because when you start a medication, actually the medication can help apathy and motivation. Also, depressed mood can improve, especially a few years after the diagnosis, because after the diagnosis, there is a shock, that's clear. And then with time, you start to figure things out, and you realize that most of the shock that you went through is because, yes, you realized you had a chronic condition, but also because of what you thought Parkinson's disease was. But some other things, including pain, tend to get worsened over time. That's why you see them on the gray part of the graph. So do we know why this happens? Not really. Most of the studies have been done looking at other non-motor problems. This is just a snapshot of some risk factors that have been looked at in determining what's causing the worsening of some of these non-motor problems. As you can see, age, type of drugs, sex, type of disease. But at the moment, we know that there are few predictors that tell us if someone is going to have pain. Obviously, the severity of the disease, motor complications, which are fluctuations and dyskinesias, we're going to talk about it, younger age at onset, female sex, depression is a big one actually, and also other problems, because if you have other problems, Parkinson's in a way makes the pain resulting from these other problems stronger. And this is actually what we think. So we think that there are some factors, think about a frozen shoulder, that is painful regardless. But in Parkinson's, that becomes more painful because of the lack of dopamine and other neurotransmitters. So the brain is more sensitive to pain. And over time, additional factors come, including disease progression. And this is when pain can also be felt without any real mechanical reasons. That's why there are different types of pain. I don't have to tell you that, unfortunately, we are dealing with a disease that tends to progress over time. And not only motor problems progress over time. Motor problems, by the way, is what you see here, up here. But look at the no motor problems. And see, pain is here at the center. But there are other reasons for pain later on. Axial deformities, which are structural problems on the spine, for example. Fluctuations, dyskinesias can also be painful. Obviously, a fall can be painful. And later on today, I'll talk about these things. So there are many causes. And this is the take-home message. I'll go back to the different types. There is a musculoskeletal type of pain, like hip pain, shoulder pain, back pain. There's the neuropathic pain. Neuropathic pain is the pain that looks like a neuralgia. So when it's electric feeling or numbness or discomfort. Then there is the one related to motor problems. Our muscles have terminals. We can feel pain in the muscles. So if someone is stressed, what you do? You go there and say, yeah, don't worry, just relax. You massage a muscle. Okay, there's a huge connection between pain, muscle stiffness, and all of it, and that can be painful. And then there is this is a word coming from Greek, akathisia. It means being restless. Okay, it's not necessarily restless leg syndrome. It's part of the restlessness that people can have, but you can be restless even during the day when the medication wears off. And then there is the so-called central pain, which is the pain that comes from inside the brain for no peripheral reason. So there's nothing wrong going on in the body, yet the brain feels pain. And last but not least, there is one important part here, which is depression. If you're depressed, you feel the pain more, to the point that even people with depression without Parkinson's have a very poor tolerance to pain. And also depression itself can be caused by chronic pain. And in case you wonder, unfortunately, we still deal with animal studies to test drugs. And the animal model of depression is a rat that works all day long. So, this is maybe a paradigm of our society. So, talking about depression, I want to talk about something that it was briefly mentioned, the impact of COVID-19. Okay, we should, first of all, tell ourselves how good we were. We went through a lot, and this doesn't come without a price. Look at this. This is a study a friend of mine from France did, and they looked at, they interviewed many patients, and they asked, okay, what worsened during the pandemic? See what's number one? Pain. So how common is this? Well, if you look at 100 patients with pain, 77% of the pain, so 3/4, or more than actually, is related to Parkinson's. So it's a Parkinson's-related pain. Other pains are not related to Parkinson's. And actually, this is another important message I need to give you today. You need to be educated about these things because you are the one telling doctors. Because not every doctor knows these things. You might have an heart attack, go to the emerge with chest pain, and they will say, oh yeah, this is Parkinson's. So you need to know that not all the pain comes from Parkinson's. The majority does, but not all of it. And then when you look at the different type of pain in Parkinson's, the most common is the musculoskeletal one. So the one related to hip problems, back pain, which is, by the way, very common in the society. Okay, so let's have a look at few of this type of pain so that we have a better sense. So this is a woman that I met a long time ago. I started seeing people with Parkinson's when I was a student in medicine, and it was 1999. So, and back then we used to go to see families with mutations of genes causing Parkinson's. This is something that was big many years ago. And this woman was found to have a mutation of a gene causing Parkinson's. She didn't have any problem. She disclosed no issue except two: depression, and look at the way she walks. Actually, she didn't even notice that. This is one of the earliest signs of Parkinson's. When we walk, we swing our arms. A very early sign of Parkinson's is that one side swings less often. And that per se doesn't cause problems. But over time, what happens is that shoulder gets frozen. And that's why often orthopedic surgeons see people with early Parkinson's disease. And unfortunately, in some cases, they even offer surgery of the shoulder. But the cause is not the shoulder. The pain comes from the shoulder. There is a mechanical reason. There is rust, as I always say, in the joint. But that comes from the fact that because of the lack of automaticity during walking, for years probably, this hand wasn't moving well. And this has actually been studied. And in this study, it was found that shoulder pain is 21 times more common in Parkinson's. So this is a patient that I still see from time to time. He lives in Italy. And he sent me this video to indicate that his posture had worsened a little bit. So you can notice two different type of problems. He's leaning forward, which we call camptocormia, in case you wonder. And he's leaning on the side, which we called, and that's easy to remember, Pisa Tower syndrome. And by the way, you don't need to be Italian to have it, okay? So this is why, probably, in Parkinson's, back pain can be way more common than the general population. But remember, back pain is common. A lot of people have back pain, so a lot of people have back pain. And then over the years, thankfully, we don't see these things anymore because we tend to prevent the occurrence of contractures. This is when you have, let's say, your hand closed for a year. Obviously, even when the muscle is finally relaxed, your joints are not going to be happy about it. So there will be rust, they will be stiff. And the same will happen to the neck and all of these things, thank you. All of these things will cause pain. So what about the neuropathic pain, the one that comes from nerve function? And here, this is an interesting Canadian story because Canada contributed with this important study done in Alberta, where they identified that in Parkinson's, often there are damage to the nerves, so what we call neuropathy. And they found 3 groups of people: Parkinson's without neuropathy, Parkinson's with neuropathy caused by something that was known, or Parkinson's with neuropathy for unknown reasons. And what they found, and this is what these complicated graphs look like, is that the more severe the neuropathy, the longer the disease, and more importantly, the more the medications. And this study led to the conclusion that if you take levodopa for many years, the use of levodopa itself can lower some vitamins, B6, B12, and those vitamins are useful for nerve well-being. Now, I grouped these 3 types together, motor, akathisia, and central pain, because this is when the disease tends to play a major role, especially with fluctuations. You know what fluctuations are? It's when your symptoms go up and down. Medication works, you feel great. The medication stops working, and you have the problems again, which we call off state. And at the same time, when the medication kicks in, you might have problems coming from the medication, like dyskinesias, which are the involuntary movements caused by medications. So this is what happens in what's being called the honeymoon of Parkinson's disease. You may take the medication 4 times a day, sometimes 3 times a day. In case you wonder, you can even take the medication once a day in the first year, and it will work for 24 hours. We don't do that for many reasons, but in short, you take your medication and the disease remains the same. But then over time, what's the longest interval between the last dose and the next one is the night, right? And over time, people develop issues in the morning. So how common is this? This is relatively common. We say that every year, 10% of patients will start having these issues. meaning that in 10 years, 100% of people without Parkinson's will have fluctuations and or dyskinesias. And actually, if in 15, 20 years, you don't have any of these problems, the diagnosis was wrong. So we are so sure about the diagnosis when we see this, when we see fluctuations and dyskinesias. That's part of the disease. So this is what I was mentioning before, the morning akinesia. Some people wake up in the morning, they had taken the medication hours and hours before, and obviously it's time to take the next dose, the new dose of the day, and this is when they feel that something is off. This is what we call morning akinesia, which is means lack of movement. And this is relatively common, depending on the stage, but as you can see here, 88% of these people with this problem in the morning end up having no motor problems, including pain. A classic one will be a cramp in the leg, which can happen in the middle of the night or early in the morning. That's called dystonia, and that can be painful. So then there is lunch, and lunch also has a problem because there is a problem with absorption of levodopa, and some people develop wearing off. Wearing off means that the off symptoms come back in the afternoon after lunch, and then this becomes more and more common, meaning that every dose doesn't last 4 hours. It lasts 3 hours, then 2 hours and a half, and so forth. And then there is delayed on. Delayed on is when you take the first dose and you need to wait an hour and a half before this dose kicks in, or something called no on or dose failure. You take the medication and nothing happens. And in case you wonder why we have these issues over time, is because we are dealing with a slow gastrointestinal system. This is a picture that the gastroscopist I work with sent me one day. He was shocked because he's done a gastroscopy in a patient of ours, and this person had taken a tablet of levocarb, you can recognize actually it's a yellow tablet, the morning, 4 hours before the test, and you wonder why that patient never had that on, why the medication never kicked in. Because it's set in the stomach and it didn't go anywhere. This is from the Michael J. Fox Foundation. So these ups and downs of problems that we call motor fluctuations, it's common. And as you can see, there's a proportion of people that can have up to 4 and more of these wearing offs or off periods during the day. But not every off period is the same. You know, at this point, you heard about the early morning problem, the nocturnal issues when people cannot roll in bed. Wearing off is when each dose doesn't last till the next dose. Then there is more different types of fluctuations, including the unpredictable off. Unpredictable off is when you think, okay, I took the medication an hour ago, by now I'll be fine, and no way, the medication hasn't worked. And this can be very problematic, especially from a psychological standpoint, because you cannot plan your day, because you don't know, okay, is it going to work, is it not going to work? And these issues, the number of issues that people might have during the off time, the motor, but also the non-motor ones, tend to go up over time. So what do you see during the motor problems, during these wearing offs or off state? You might see motor problems, the classic ones, but you can also have a lot of non-motor problems. Guess what? Including pain. So some people have no pain until the medication stops working. That's why we're talking about these things. So what happens to this pain with regard to medications? This is a general rule that applies to anything, not just pain. If you have something that goes up and down, it can be anything, including a headache or a tingle, whatever sign, you need to go to the bathroom, anything. If this problem goes up and down during the day, and you notice a connection with the medication, meaning that when the medication kicks in, this problem goes away, that's related to Parkinson's and to the lack of dopamine. And this is what's shown in this table. You see a number here of non-motor problems on the left, and you see if they are more common in the off versus the on state. And most of them are more common in the off state, meaning that the medication actually helps. So if the pain comes only during the off time, you don't have to take a painkiller. I see so many patients taking Tylenol for no reasons. You just need to take the medication for Parkinson's. And that's another way to look at it. The severity of each of these problems, any of them, anxiety, depression, fatigue, as you can see, the severity is always lower when the patient is medicated. There's one exception here, which is happiness, but it's the other way of looking at depression. So happiness is more when the medication is on. And the other exception is sweating. So sometimes people sweat because of dyskinesias. That's why medications don't help. From a more scientific standpoint, we have this issue because there are neurotransmitters in the brain. So there are molecules in the brain, not just dopamine. They are missing, they are lacking, they are not enough. And when you look at pain, which is here at the bottom, you see that most of the neurotransmitters in the brain seem to be related to pain, and they are lower. Have you heard about patients who get too happy in the on-medication condition? They can be manic, they can be ecstatic when the medication is very high. For the same reason, when the medication is very low, they can be depressed. And once again, people are given antidepressant, but no reasons. You just need to treat the fluctuations. So this is no motor fluctuations. It's just another way to look at things in terms of mood. And this is when there is an interplay between mood and pain, because obviously in the off state, if you're depressed, you will feel pain more often. I met a lot of patients in my life with shoulder pain, carpal tunnel, and they will all tell you, look, this is the problem, I have it all the time, but when the medication wears off, I have more. Here, the medication is not necessarily going to fix this pain, but it's going to change the threshold for pain. So there is a reason in the periphery, but the fluctuation still plays a role, because when the medication is on board, the brain is less sensitive to pain. Now, this is an interview that I actually published, I think, yes, a few years ago, last year, with a patient of mine. She's had something called dopamine dysregulation syndrome. Humans tend to do over and over what they like, actually not just humans, any animal. So if the medication gives you happiness or it doesn't give you pain, then the brain learns that medication means good thing. The problem is that things can get out of control. This is what happens, for example, with pasta with me. I like it so much that I can't stop. The same with medication. So this person has dopamine dysregulation syndrome, meaning that she's addicted to levodopa, and I'm interviewing her after deep brain stimulation. When did you take your last dose of levodopa?
Right now.
Right now? Mm-hmm. So you take the medication every hour now. Mm. Do you take it also at night?
Mm-hmm.
Every hour, even in the middle of the night, you take it. And what happens if you don't take it?
It's stiffness and pain.
You have pain and stiffness. Before DB.
So I was on the patch before.
Okay, let me pause for a sec. So as you heard, she's not taking the medication because she can move. She has DBS. Actually, she has dyskinesias. You probably noticed she's moving too much. She's taking the medication because otherwise she feels pain. And that's why the addiction kicks in. This is another case. This is the opposite extreme. This is a man who used to use a dopamine agonist. You know, pramipexole, ropinirole, rotigotine, these are apomorphine. These are dopamine agonists. These are drugs that mimic the effect of dopamine. They were on the news for a while in the past because these were the drugs causing gambling, shopping. These are the class of these drugs. But these drugs are also useful for mood and apathy. That's why if you take too much of it, then you start becoming a little too interested in pleasure. So, and obviously, because we are always afraid of causing these issues, we try to get rid of this medication. So this man was on a patch, which is a dopamine agonist, and after surgery, after DBS, we stopped the patch. He was moving very well, but he wasn't happy. Something was wrong. And let's hear what he has to say.
So I was on the patch before I had my DBS surgery, and I wanted to come off the patch because I'd been reducing from 10 milligrams down to 4. And then a few weeks, about 3 months ago, I spoke to the doctors to get off the patch completely. Mm-hmm. As soon as I went off the patch, about 4 weeks later, when I was sort of off the agonist completely, I started to feel very apathetic. And I mentioned this as we were doing the work that we've been doing together. And we went back onto the patch of 2 milligrams. And as soon as I put the 2 milligram patch on, the same day, I lost my apathy, according to my wife.
According to his wife, which is very important. So that's the other side of that. So in other words, these drugs are good to keep your mood good. If you use too much, then you can get addicted to it. But if you don't use it enough, it's not just a motor problem, but also non-motor problems of any type, including pain, depression, apathy, as you heard, can get worse. To the point that when we stop the medications, we need to monitor now to see if these problems come. And obviously, I always listen to a good family member. Have you seen when you board a plane, the flight attendants, they look at you and they greet you? Actually, they do it because they want to see who you are in case of problems on the plane. They want to see, okay, where I can go to ask for support. Doctors do the same in a way. When I see patients in my clinic, I judge, actually very often, the family. I need to see a caregiver, a care partner who is really involved. I don't like when the patient comes alone, or especially when they're discussing important topics like deep brain stimulation. Or I don't like when the patient comes in the clinic room and the caregiver is reading the newspaper. That tells you a lot, right? So I always see what type of family member I have, because I need to understand if I can rely on their support. In this case, this man, I really trusted his wife. So when the wife said, no, it's not the same, okay, I knew that something was off. So let's talk about dystonia. Have you heard about dystonia before? Okay, dystonia is a contraction that is a little more sustained. It's like a torticollis or a cramp at the hand. And in Parkinson's, dystonia can occur at different stage, and we're talking about dystonia because dystonia, exactly as rigidity, can be painful. Very early in the disease, you might see that some people have food dystonia. Later on, there might be dystonia with the ups and downs of medications, and I'm going to show you a few examples. And later on, you might have fixed dystonia, when the posture tends to be a bit more fixed, and this is where physiotherapy becomes really important. So let's have a look at a few examples. This is a man with a foot drop. The foot, when he walks, as you know, if you can see it, slaps on the floor. And this has been seen by many orthopedics, but this is an early sign of the disease. It's the dystonia of the foot. That's not painful. That's where pain can happen. This is another case. This is Parkinson's caused by a mutation of a gene called Parkin. And in this condition, you might have more dystonia that is fixed. And he has dystonia not just of his feet. As you can see, tiptoeing when he walks. And when he runs, by the way, dystonia goes away. But he also has a posture. The dystonia also affects his trunk, and he tends to lean forward. And that can also become painful. This is a big problem here. This is an off dystonia. Dystonia in off can be really, really severe, especially many, many years after the disease onset. And this is a man where DBS really saved his life, because when DBS is turned off, and this is what happened in this video, he has this severe dystonia that can be very painful. Dystonia can also have funny appearance, like this one that we call the flamenco dancer posture. So some people, when they have dystonia, the hand goes up. In other people, instead, there's something else, especially affecting the respiratory muscles. This is a woman that can't breathe or swallow in the off state.
Okay, what is happening right now?
Well, I can't exhale very easily. I can inhale easier. But when I talk, I don't have any strength behind my diaphragm. My
Face
diaphragm
the
is
story.
strong.
And this is on
Right, so
levodopa.
what happens? Just
Everything
give me,
goes away.
Maybe like
So levodopa in any person goes up and down. And depending on the dose, you might have different curves. Sometimes it's never a good dose and it only causes problems. Sometimes it's a good dose. Sometimes it's too much. And depending on the ups and downs of the medication, you might have different issues. So these are involuntary movements associated with restlessness. So this is when the patient doesn't feel okay. Something is off. They want to move their legs. The legs move also on their own. Sometimes there's a little bit of dystonia together with it. These are like involuntary movements. And then you might wonder, okay, this is because of the medication. No, when we see this, we know it's because of not enough medication. So lower limb involuntary movements, especially when there's a little bit of restlessness, is something we call biphasic dyskinesias. And this is when there's more medications needed. It's the other way around. And this is the same person with more levodopa. So this is the transition between between off and on. In this transition, when the dose is there but is not enough, you might see these issues. And this is what doctors know, that depending on where we see these movements, this dystonia, these dyskinesias, we think we know what type of approach we need to use. Dystonia sometimes is worsened by levodopa, like in this man or here on the right. Some people do this when they walk, when they are on too high dose of levodopa, and that can become painful again on the shoulder. So what's the practical approach to pain? As I said already, the question is this fluctuating? Anything fluctuating, you need to think it might be Parkinson's. And you know this. The doctors, the GPs, the cardiologists, many neurologists, unfortunately, don't know this because these are rare things. Poor family doctors, they need to know a lot of things. They need to know how to deliver a baby, and you cannot expect them to know these things. So you always need to teach doctors about these issues. So if the pain goes up and down, it might be related to Parkinson's. If not, it's less likely related. But remember, the lack of levodopa in some situations can exacerbate the way the patient feels the pain. If it's partly, it's probably a combination of PD-related and non-PD-related issues. And when it's fluctuating, as I said, it's most likely related to Parkinson's. And we discussed dystonia, rigidity, and also neuropathy. The neuropathic pain can go up and down with the medication. So how do we treat pain? Let's avoid painkillers. Let's say it once and for all. Yes, sometimes you need to use them when the pain is really excruciating, you want to get rid of it, fine, I'm nothing against it. But there is a problem with abuse of painkillers. This is a randomized controlled trial, very important kind of study, published in a very prestigious journal called Lancet Neurology, where they looked at an opioid medication, which is oxycodone, for pain in Parkinson's. So it looked like an easy study to do, and it was negative. So oxycodone wasn't better than placebo. And so the first thing then is to avoid painkiller whenever possible and to treat the fluctuations. Because I mentioned already, I gave you enough examples that these ups and downs of medication is not good to the body and can cause pain. Avoid taking too much medication on your own. Obviously, if your doctor tells you, okay, but if you do things on your own, there's a risk that you start to develop an addiction to medications. And if these things are not effective, then there are different approaches. I'm going to show you botulinum toxin, injections of botulinum toxin. There are drugs. As you see here, there is one compound that I'm sure you wonder about, which are cannabinoids or cannabis. There is a session on this later today, so I won't touch upon this. I just want to say that yes, cannabis, particularly CBD, might help, but it's not that effective in my opinion, because studies haven't really shown a dramatic effect. It's very individualized. Some people do well, some people don't. So be careful anytime someone says, oh yeah, that treats all pain. This treats everything. Unfortunately, panaceas don't exist in medicine. There are other ways to help pain, chronic pain, antidepressants. Antidepressants when there is depression, antidepressants even when there is no depression. This is because antidepressants raise the threshold for pain. You probably heard about trigeminal neuralgia. In trigeminal neuralgia sometimes, or in fibromyalgia, even when there's no depression, the doctors use antidepressants. So this is a nice review paper that was published by a group in Calgary last year. And the take-home message here is that there are different types of pain, as you heard on and on today, over and over. And depending on the type of pain, there are different approaches. This is just a snapshot to indicate that we have different drugs used to help Parkinson's. Obviously, levodopa is the main one. Levodopa becomes dopamine in the brain. You already heard about dopamine agonists, which are drugs that mimic the effect of dopamine, and they are stimulating the same receptors. And these are the drugs that we use very often. When medications are not effective, we tend to use advanced therapies. Deep brain stimulation is one of them, which is basically a pacemaker for the brain. There are different targets in the brain. We have thalamus for tremor. We have subthalamus for many of the cardinal signs of the disease. We have globus pallidus for dyskinesias, dystonia. So depending on the problems, the doctor decides where to go with the electrode. Is deep brain stimulation effective in treating non-motor problems? Not always, actually. And pain is not one of the problems that is often treated by deep brain stimulation. Why? Because deep brain stimulation, as you heard in the patients you've seen before, takes care of motor problems. But sometimes you need the dopamine part of the equation to resolve the pain situation. So some problems do better, like sleep, if sleep is caused by a lack of mobility in the middle of the night. But if sleep is not better because of restlessness in the middle of the night, the DBS is not going to help you. This is when we need to use dopamine agonist or levodopa at bedtime. And this applies to all the classic non-motor problems you heard so far. I put a slide here about focused ultrasound because it's something that is very popular these days, and I just wanted to make sure that you went home also knowing something about focused ultrasound. Focused ultrasound is basically a very expensive microwave oven. So you put your head in a microwave oven in an MRI, and it's $1 million or more. With these microwaves, we converge all these microwaves in a specific part of the brain, and we kill those neurons. So even if people think that this is not surgery because there is no opening, it's actually a surgical procedure. And you can actually even see at the MRI how it looks like. This is a thalamotomy. This is a pallidotomy. So you can actually see the damage that focused ultrasound created in the brain, not because we want to damage the brain, but because we want to get rid of those neurons who are doing a bad job. But it's a brain operation. So it doesn't necessarily help much with pain. It depends, again, on the type of pain. If the pain comes from dystonia or dyskinesias, yes, pain can help. The focused ultrasound can help with a pallidotomy because the pallidotomy will take care of these problems. So how do we treat in general of periods, which is the fluctuations that we were talking about before? There is one approach, which is the one that we should all aim for, which is preventing. We don't want people to even have them, right? But sometimes, in spite of best intentions and very complex medications and surgery and so forth, people might still experience some fluctuations and some sudden off, for example. And this is where rescue drugs can be beneficial because some of these sudden offs can be painful. There are different ways to bypass the stomach, and there are new products available in Canada like apomorphine sublingual. That's something that it's placed under the tongue and it kicks in about 15 minutes. In the States, there is also an inhaled formulation of levodopa. It's like a medication for asthma. I don't know if you've seen this puffer, but it's with levodopa. So that, again, the goal here is to give something that works right away to revert the off period. Rotigotine patch, you heard about it before. It's a dopamine agonist, so we try to use it only when needed, but as a good thing, which is a patch. Being a patch, there is no ups and downs. It's a constant dose. And in this paper that I did a while ago, we've proven that it's actually effective even in people who are usually not candidates for dopamine agonists, obviously a low dose. We're talking about people over 75 in this case. So how can we use rescue medication? So there are different approaches. I already mentioned the sublingual apomorphine. There is also an apomorphine that can be injected under the skin, like a EpiPen. Crushed levodopa is something that can always be done. So if you crush your levodopa and you drink it with carbonated water, it will kick in faster because it will pass through the stomach faster. There are other approaches that are not available in Canada. So these three are the ones available in Canada. And this is just to show you that in some situations there are effervescent tablets of levodopa. This is not available in Canada, unfortunately, but this is just to make the point that a liquid levodopa kicks in faster, and that will be useful. Apomorphine is not morphine, okay? That's a common misunderstanding because in Canada you also have generic formulation. You have Apo levocarb, Apo whatever, but this is not the generic formulation of morphine. If you were to have a generic formulation of apomorphine, it would be apomorphine, okay? So. But that's a common misunderstanding. So apomorphine is very similar to dopamine and only partially similar to morphine. This is the pen jet looks like. This kicks in 5 to 10 minutes. And the dose has to be adjusted by the doctors in hospital. And that's the one that you already heard of, the sublingual apomorphine. Same drug given under the tongue. It takes a little longer to kick in. We can skip this. So just a few words about dystonia and rigidity. Remember, fluctuations is the key. We need to get rid of them. But also dyskinesias are not good. Dyskinesias of different types can be painful. And even here, botulinum toxin and advanced therapies can be beneficial. Dystonia needs to be treated because besides the pain, dystonia in turn can cause additional issues. This is a man that I used to follow, and he had dystonia and Parkinson's for so many years that wasn't really treated well, unfortunately. And over the years, he developed a cervical myelopathy. Because of the continuous dystonic movements of the neck, he ended up having a trauma, an issue with his spine. So the pain initially could have been caused by the dystonia of the neck, but then it became caused by the myelopathy. So there are many reasons to treat these things. This is a man with Parkinson's and cervical dystonia. So the neck in this case wants to go backwards. And I'm showing you this because cervical dystonia can be very painful. Let's hear what he has to say. So how is the pain now?
It's pretty bad.
On a scale that goes from 0 to 10, how much is it?
In the mornings, it's in the 7 to 8 range.
And where is the pain?
It's basically, sometimes it's actually worse one side or the other.
So this is where I inject this man with botulinum toxin. 500. This is in the right splenium. The cable is here, the cable of DBS. You hear this sound? This is the muscle. So we use EMG to make sure that we're injecting in the muscle that is working too much. So this is after the treatment?
The injections, about 2 to 3 weeks after, I noticed quite a difference in the pain level. It was much lower than previously. It had been at pretty much the highest level. And
this is the same person 2 years later, still having benefit. This is right before the injection, and he used to take 3 painkillers a day, and he went down to 0. And then he starts taking again painkillers before he sees me again, because unfortunately the toxin doesn't last more than 3 months. And by the way, you always call it Botox, but Botox is just one of the brand names. There are 2 other, Xeomin and Dysport, approved in Canada. So the compound is called botulinum neurotoxin. It's like Kleenex kind of thing. Dystonia can also be treated, as I mentioned earlier, with DBS of this target called globus pallidus. This is an example of a patient with Parkinson's and dystonia. And nowadays, we are also using new devices that are helping us understand the brain a bit better. We can analyze certain brain waves, and we know that depending on the type of brain wave that we record in the brain, we can tell what type of problems this person is having, also over time when they go home. So we can follow the brain activity over the years. And depending on what we record, we say, okay, at 8:30 last night, this man had tremor, this woman had dystonia, and so forth. And we are now using this. This is how the programmer that I used for deep brain stimulation, we are using this also to program patients, because we can look where the bad signal comes from in the brain. And depending on where it's coming from, we can select different contacts, trying to abate this pathological signal instead of killing the neurons. We use electricity to numb these neurons. And with this, I want to go back to the take-home messages. Remember, pain is common. I think you had enough pain today. Affects the quality of life. I don't have to convince you about it. There are different types of pain. It can get complicated, I realize that, but the message for you is just to realize that there are different types of pain, because depending on the type of pain, the doctor will need to do different things. But remember, if the problem fluctuates, chances are that that's coming from Parkinson's, and simply treating Parkinson's will be beneficial without using painkillers. And as I mentioned already a couple of times, not every doctor is aware of this complexity. So You got to tell them. You're going to teach them so that they know what to do next. Thank you. Thank you. So we have 10 minutes, second, right?
Can I have a mic? Thank you. Well, that was amazing, wasn't it? My goodness.
Cheers.
So we have just 10 minutes for a Q&A with Dr. Fasano. Same process, if you just hold up your hand, there are 2 circulating microphones and staff will come to you.
By the way, thanks for letting me go through the tables. You know, a couple of times I was probably about to fall, but people were fast enough to take the leg back. There's a
Over
question
there.
here,
At the back.
and there too. Maybe you start there because the microphone is there. Okay.
That was just fascinating. Thank you.
Thank you.
I'm a caregiver. I was particularly interested in your comment that you also kind of check out the caregivers. So what are the key roles for us, the central?
Let me tell you, you're a good caregiver because you're here, first of all. Second, because of the question. And I don't think I need to tell you what you need to do because the fact that you asked the question already tells me a lot about you. But if we want to talk about the general role of caregivers, caregivers are there not just to be nice. They are actually, you know, the famous tough love is key. It actually has been shown that especially men, if they're alone, they do a lot of, they get into troubles, okay? I also women, but you know, I think I can talk for the category of men, and I can tell you that men tend to be troublemakers more often. And hopefully it's not sexist, because, but simply the presence of a wife or any, you know, partner, husband, whatever, in someone's life helps because they feel they are judged. They feel that they can't stay all day long in their pajama in bed. You heard before, you know, the rule of avoiding sitting in front of the computer and checking emails, which actually is something I do every day, and to, you know, you dress up and you put clothes on, I mean, and you go out for a walk. You do this more often if there's a caregiver that is there to sometimes even say nothing. The fact that there's someone at home, the person, oh, let me do it, otherwise I'm going to be in trouble. So this kind of activity is also important. The other reason we rely a lot on caregivers, as you heard before, is behavior. I see hundreds of patients, and often I see these patients for the first time in my office, and I need to judge if they're good or not candidates for an advanced therapy as deep brain stimulation. So I really need to see what the family has to say, you know, because if they tell me, oh, it's very impulsive, I have no way in an hour and a half to understand how that person is. And even more importantly, after surgery, sometimes what we do changes patients' behavior. They may become too happy, sometimes too much, or too depressed. And I don't live with them. The wife, the friends, the husband, whoever is there can tell me. Sometimes actually I force them to move to their kids' house if they are by themselves, because I need someone to keep an eye on them. So there are multiple roles in caregivers, and I perceive this work as a team effort. I'm not saying just for the sake of saying it, but it's really a key to be part of a team. I go back to aviation once again. In aviation, there's something called crew resource management. I feel that I'm more like the pilot that is running a cockpit, but in the cockpit, I'm listening to everybody, including caregivers. Actually, they're very important. And there are many, many other roles. But in short, really, you're doing your part already, I can tell. So whoever you are taking care of is a lucky person.
How many caregivers are there in the room? Raise your hand, please. Woohoo! Thank you.
I think there was a question here.
We'll go side to side if you don't mind. There's one here, and then we'll come back to the other side.
So I realize I need to talk less. It's because otherwise, yeah, it's a problem with Italians. Go ahead. Yeah.
No, just a minute. Okay. My question has to do with neuropathy. My husband has had Parkinson's for 18 years. He takes 1.5 of the dopamine 8 times a day. He's managed that very well. Our biggest issue is peripheral neuropathy of the legs, which really complicates his mobility, which really makes a huge difference. And we're told everywhere we turn to date that there's nothing we can do. Would you agree with that?
It depends on the type of neuropathy.
Yeah.
So some neuropathies have no cause. No cause. They have a cause, it's just that we're ignorant, that we don't know what's the cause. I'm talking about the doctors not knowing. And this is what we call idiopathic neuropathy. Anytime you hear idiopathic, it sounds very cool, but it means the doctors haven't figured it out. Unfortunately. So if the neuropathy is idiopathic, I'm afraid there is nothing to do. But often, as you heard in my talk, neuropathy is related to lack of vitamins. So at the bare minimum, your husband needs to be tested for B12, B6, homocysteine, methylmalonic acid. There are, if you want, I can write it down for you later. But there are certain tests that need to be done, and I'm sure he's done it, because it will be. I guess when he was diagnosed, they ordered blood work. Right? Did they do any blood work? They tried to, but also when they use the machines, at most hospitals where we were, the machines aren't working and there's nothing we can do. Oh, okay, well, that's a little bit concerned. It was this, I mean, she's saying, probably you haven't heard that the machine, I guess you understand, it's the electromyographer. The electromyography wasn't working. I'm assuming this was during the pandemic. I hope at least it was during the pandemic. No, okay, so we need to talk, okay.
So you can follow up.
Yeah,
Dr.
we'll
Fasano is
talk
quite
later,
willing,
so that.
So
yeah.
we'll leave that. So I know there were a couple more questions on
So
this
there were
side.
there, here, yeah.
Hands up so that the.
So maybe I can give the microphone here right away, so that you had a question, right?
Oh, okay.
Go for it.
So my question was, first of all, thank you for the comment about men with Parkinson's, because I sometimes feel I have to give tough love to my husband. He has always been a baby when he's sick. And now with Parkinson's, it's sometimes difficult to tell if he's just, being a baby, or if he actually is in pain. And so we're struggling with that in the house. Just, is he really in pain or is he not? But my question is related to the treatments that you showed that are not available in Canada. Are they going to be available in Canada, and why are we always slower than other countries?
Okay. Very good question. So let me tell you that, first of all, there's a reason why they call it men's cold instead of just cold, right? But how long have you known your husband? Many years. For sure more than the doctors. You know when it's Parkinson's, it's a real struggle, and it's just when he's being himself, right? Because everybody is different, and you cannot change the way he is. And at the end of the day, you chose him the way he was, right? So you can only blame yourself. Fair enough. Second, about the drugs, I want to say something, and I'm glad that there is also a politician in the room, because I've been impressed, or a former politician, I don't know, nobody's perfect anyways, don't worry. But I'm been impressed by the way politics are in Canada. Obviously, people always comment and judge politicians and healthcare and public healthcare and Ministry of Health and all of this. But I've been practicing in Italy, in Germany, a little bit in Spain, and in Canada. No system is perfect, but Canada has a good look at the cost of things. So all the new things that I showed in the slides are not necessarily better. They are more expensive, but not necessarily better. And in Canada, let me tell you, if something is working and it's needed, it's gonna come. And it comes also quite fast. Subcutaneous apomorphine, for example, which I didn't talk about, is a new pump that gives the medication under the skin. It's gonna be approved in Canada as the first country ever in the world, I think, or right after the US, well before Europe. And it's usually not the case. Then there is another issue with pharmaceutical company. Pharmaceutical company go where the money is, right? That's their job. And Canada is 40 million people, you know, the market is not so good. So that's why things tend to get a little delayed. But let me assure you that the healthcare system, with all the problems, we just heard about the electromyography not working, is one of the best I can possibly think of. And going to the States, I see a lot of patients who go to the States. In my experience, has never helped anybody. I'm telling you, I can be, you know, I can even write it somewhere and sign it. Going to the States is very rarely the solution for Parkinson's. Obviously, if you want to look into something very experimental, different story. But you're not missing out. That's a message. There were other questions there. Yeah.
Hi. I was just wondering, how do you know when it's time to go up on your medication, the levodopa?
Yeah. So levodopa, there are two reasons to increase the dose. One, when the symptoms are still there, we call resistant signs, so they need a little more, usually, for example, freezing of gait. I'm going to talk about this later today. We might need a bit more levodopa. Second, when levodopa doesn't last long enough. So to make it last longer, you give higher dose. The problem is that when you increase the dose, yes, it lasts longer, but it can cause dyskinesias because the dose is too much. So the brain wants little more often rather than a big dose 3 times a day. But we have to do it because, taking a medication every hour is not perfect, right? So in my mind, because I always say, okay, if I were a patient, probably the last thing I would like to do, the last resort would be every 3 hours, but no more than that. So instead, there are people, unfortunately, who need to take it every 2, every 1 hour. That's why there are pumps. The pump will do the job for you instead of increasing the dose. I think we're done, right?
I think we are out of time, unfortunately, for questions. I know Dr. Fasano will be around because he's doing a breakout session later in the day. So again, thank you so much, sir. That was an amazing presentation.
Thank you.